Good morning, everyone, and thank you for joining us today. My name is Alma Ahmed. I'm part of the student network team, and I will be hosting the webinar. Just a little bit of housekeeping before we begin. The webinar is going to last approximately 1 hour, and at the end, we will have questions and answer session. So if you have any questions as we go along, please feel free to type them in the question box, and I will run through them at the end of the webinar. We are very lucky today to have Robyn Puglia with us. Robyn is a nutritional therapist and IFM certified functional medicine practitioner. She specialises in autoimmune disease, gluten-reactive disorders, including celiac disease, complex cases and unexplained illnesses. She has a busy clinical practice, but also provides technical support and education for Regenerus Labs. That includes doctor's data, Dutch labs, BCA, Lyme, and viral labs, and Cyrex. Robyn is a well-regarded speaker and lecturer in the UK, presenting on autoimmune disease, gut health, complex biochemistry, and clinical case studies. So today's webinar is entitled An Introduction to Autoimmune. In this webinar, Robyn will explain how leaky gut, genetics, and environmental triggers such as toxins, food sensitivities, infections, and stress all play a part in the development of the autoimmune disease. And she will teach us how to begin unraveling the mysteries of these complex cases. So without further ado, it is my pleasure to introduce you to our presenter. Robyn, please welcome.
Hi, thank you very much, Alma. Thanks for inviting me to speak this morning about this subject, which of course I love and talk about a lot. So I'm going to try to basically do a fairly broad overview of what are all the jigsaw puzzle pieces that you need to be thinking about when someone presents in your clinic with an autoimmune condition or a suspicion of autoimmune condition. And it's not possible for me to really dig deep down into every single variable because there are so many. So I'm basically just going to be highlighting the things that I think are most important for you to be considering and some information about what that looks like. And then when you're putting together a program at the end, I've also created a kind of a summary on what are all of the things that you need to be considering, because it's not just as simple as your person has autoimmune disease, you need to put them on this autoimmune disease diet. It's there's lots of shades of grey involved in that. So without any further ado, let's talk about autoimmunity. So firstly, what is autoimmunity? So autoimmunity is basically the failure of an organism, in this case the human body, to recognize its own constituent parts as self. Essentially it is loss of tolerance to self, loss of immune tolerance to self. And when you lose immune tolerance to part of your own body, this sets up an inflammatory reaction that is directed at that tissue. And when that inflammatory reaction gets to the point where it's debilitating, then the disease that arises from that mechanism is called an autoimmune disease. And what is an antibody? So we do talk about antibodies all the time, but an antibody is basically an immunoglobulin. So it is a protein that the immune system uses as a flag. So it attaches this flag, this antibody, to another protein, and that signals to the other parts of the immune system, yoo-hoo, there's a problem here. And then that triggers the inflammatory response to the immune complex. So the immune complex is the protein and the antibody together, that's the molecule that's made up of those two things. So there's an image of an immune complex there on the slide. And because that protein has been flagged by the antibody, then you end up with an inflammatory reaction, which comes from other T helper cells usually. So when we're talking about autoimmunity, those two things are sort of at the very core of that. So there's always antibodies involved directed at tissue, which tells us something about the immune response, and that it is a loss of tolerance to self, essentially. So there are more than 80 distinct and separate autoimmune diseases, and it's estimated that something like 5 to 8% of the population have a diagnosed autoimmune disease. Actually, I think that number is currently more than 150. There's a list on autoimmuneregistry.org, which is a not-for-profit website in the US that includes all of the autoimmune diseases that are confirmed, but also any disease that has no known cause and is suspected of being autoimmune in at least 3 separate reputable papers in PubMed. And that number is more than 150 and growing all the time. So I also think that the percentage of the population that have autoimmune mechanism involved in their illness is actually around 20%. I think that there are people walking around in a state of preclinical autoimmunity, undiagnosed autoimmune disease, and where the autoimmune mechanism is involved. So I think that autoimmunity affects a higher number than that 5 to 8%. Oh, in fact, my next point is early stage autoimmune symptoms and immune dysregulation are present in 10 to 20% of the population. So it's very, very common. I'm sure you all know that. There is a lot of discussion around it in our field at the moment. And that's because it's part of this growing tide of chronic illness that's basically overwhelming us. So whatever your specialty, you're going to be seeing autoimmune disease as part of people who are presenting in your clinic, because it just affects so many of us now. So here are some of the, I wasn't going to list all 155 conditions, of course, but here I decided to actually list the ones that I think are common because I see them in my clinic relatively regularly. So that's these ones here. And part of the issue around autoimmunity, of course, is that they can share really similar symptoms. So it can be very difficult for healthcare professionals, us or the medical community, to pinpoint a specific disorder, especially in the early stages. But common symptoms tend to include things like fatigue, aching muscles, aching joints, aching sort of musculoskeletal system, inflammation, and various different signs and symptoms associated with inflammation, such as skin rashes and flushing and susceptibility to infection and things like that. There is a very distinct gender bias towards autoimmunity. So many more women than men have autoimmune disease. The exceptions to that are type 1 diabetes and inflammatory bowel disease, where in type, no, I never remember which way around that is, but in one instance, the numbers are pretty equal, and in the other one, it's slightly more male dominant. But they are the 2 exceptions of that 154. So as with, I guess, all chronic illnesses, autoimmune disease doesn't just fall out of the sky and land on you. You don't wake up one morning with rheumatoid arthritis when the day before you had healthy joints and healthy immune system. There is this, there's a spectrum and a pathway that autoimmunity follows from healthy optimal function until right down the other end of that we have diagnosable disease that is affecting the organ or the system so badly that quality of life is significantly disrupted, and we start to see things like severe joint deformation in rheumatoid arthritis and things like that. But because there is the spectrum, because there's this massive timeline between healthy and end stage, we as nutritional therapists, we have this really beautiful window of opportunity to make changes if we can identify that there's a problem early, and if we can get it before it's at the very end stage. We have this unique opportunity to actually try to turn that ship around and reverse some of the disordered immune mechanisms and address some of the triggers that are leading the person down that path. The reality is that most people are not diagnosed until they're pretty far down that pathway, but people can be very sick for a very long time and have symptoms for a very long time before they get to the stage of autoimmune disease. So again, as nutritional therapists, we're seeing things like IBS and gut symptoms, things like eczema, psoriasis, indications of immune system dysfunction. And if you're taking a really comprehensive history and you can see, okay, so this person is presenting in my clinic with IBS, but their mother has rheumatoid arthritis and Aunt Sally has, I don't know, type 1 diabetes, let's say. that person is at a really high risk for autoimmunity, and therefore identifying issues early, because that person is 22 or 25, means that maybe they don't get diagnosed at 45. So we know that antibodies are actually present in the system for 10 or even 20 years before diagnosis is possible. So testing antibodies and looking at immune function really early on, and I really feel strongly about this, especially in children. If you're working with children in any capacity at all, or you're working with parents, then identifying any vague suggestions around inflammation and less than optimal immune function is super important in children, because if we get it early before it's even at antibodies, when it's still just at inflammation and disrupted barrier function, then we have this opportunity in that next generation to really reverse the trend that we're seeing now, where we're kind of being overwhelmed with autoimmunity. Children are actually where we're going to be able to make that change by identifying it like early in that autoimmune activation, where you've got the triggers when they're in that pre-symptomatic phase. So with autoimmune disease, we always have two different, we have this interplay between the two different parts of our adaptive immune system. So we have the T cells, and T cells, of course, differentiate into killer T cells, T helper cells, T regulatory cells, and memory cells. And that's really important when you're understanding autoimmunity, because it's a very big part of the inflammatory mechanism in the immune system. And then T helper cells split up into Th1, Th2, Th17, T follicular cells, Th22. I think there's 7 pathways now that have been identified. So we used to think about it as just Th1, Th2 balance, and that Th17 was a very aggressive autoimmune pathway, but it's becoming, as the more we understand the immune system, the more complicated and like beautifully complex it actually is. So T helper cells basically produce cytokines. They're communication cells and they're inflammatory cells. So they drive immune response and inflammation, and they are in constant communication with the B cells, which I'll talk about in a sec, which are where the antibodies take place. So with autoimmunity, what we often see is this really complicated dance and really complicated communication between the Th cells, Th1 to 17, and the B cells, in order to identify that there's a problem, respond to the problem, and to initiate that entire cascade of immune response. And then after that, we should have in a healthy body T regulatory cells that come in at the end of that necessary inflammatory process to switch it off and calm everybody down again. So T regulatory cells are very involved in tolerance, which of course is the mechanism that's broken in autoimmune disease. So it's a really, supporting and understanding T regulatory function is a very important part of working with someone that has autoimmunity, because it's a very big way of how we're going to teach the immune system that it's okay to switch off and calm down now. So T cells are matured in the thymus glands, and they go on to differentiate from there. And then some T regulatory cells are further differentiated in lymphatic tissue, such as the the GALT in the gut, so the gut-associated lymphoid tissue, and also things like your nasal-associated lymphoid tissue up in the respiratory tract. And antigen presentation cells play a really big role again in immune response, and I'll talk about that a little bit more when I'm talking about the genetics of autoimmunity. So then we have adaptive humoral immunity, and so this is where we have B cells that make antibodies. So the mechanism for all autoimmunity is as follows. So something triggers the T helper cells and the B cells. Antibodies are produced, and these are antibodies to self-tissue in the case of autoimmune disease. And then the control mechanism for turning off the T helpers fails, right? That's your T regulatory function. the immune system launches into action, basically, and then inflammation and oxidative damage occurs to the cells and the tissues in the surrounding area. And that is autoimmune disease. That's the basic mechanism for autoimmune disease. And when that's been happening without being switched off because T regulatory cells aren't being activated or they're inefficient, then that cascade turns into disease in the end. So basically your B cells produce antibodies. The antibodies are then looking for a very specific antigen to attach to. So usually we're making antibodies to attach to bacteria, viruses, chemicals bound to tissue. Chemicals themselves are actually too small to elicit an antibody response. Foreign molecules of any kind. And the B cells then essentially initiate that inflammatory response from the T cells. So it's the T cell cytokines that are actually doing the damage once the antibody has identified the tissue that's going to be attacked. So there are 5 classes of antibody. IgM, which I always think of as the big mama antibody, and anybody that studied with me at ION will know exactly why I think of it as big mama and hopefully be having a giggle to themselves. Maybe I should explain that, but maybe I won't. I'll be mysterious about it. So IgM is the big mama. It's the biggest of all of the antibodies, and it's the first response. So we see that in an initial immune response to something like a bacteria or a virus. And it's very, very inflammatory, but it's also short-lived. So we don't see that for very long in the system, which is why we can identify that it's a recent issue, with the exception of in some cases when, for example, if Epstein-Barr virus is reactivating because it was in a different life cycle. When it reactivates, it is very similar to having an initial infection again. So you sometimes do see IgM antibodies coming back up again if someone has a chronic infection, but it's usually indicative of it being a recent problem. IgG is a much smaller antibody than IgM, and IgG and IgA back each other up. They're both very small. They're very similar to each other, but IgA has a slightly longer tail or chain in the tail. IgA is much more associated with autoimmunity in general, and it's kind of considered to be a more established immune response. IgG can come up first, and then once that has been unable to appropriately respond and deal with the the immune trigger, then IgA will come up behind it and take over. So I usually, when I'm seeing things systemically with an IgA response, I understand that that's been there for quite a while and we now have a really established immune issue with it. So of course that depends a little bit on the location though, because IgG is the most abundant immunoglobulin in the systemic circulation, but IgA, because of secretory IgA, is the most abundant immunoglobulin on the gut, on the mucosal surfaces. So in a gut, in a lumen response that's happening on the gut wall, IgA is much more likely to be the first responder and IgG is the backup. So nothing is really set in stone with these two because they act to support each other. So you can kind of use that information along with clinical history to make some educated guesses, but nothing is ever 100%. I've put IgG there twice. IgE is supposed to be the next one along, which of course is associated with classical allergy. And IgD is a bit of a mystery, to be honest with you. So we don't really know very much about what IgD does and why it's there. And nobody's really looking at it that closely. And I suspect that we're going to find out that IgD does something that's really important, because the body doesn't do anything for no reason. But to this date, why is not very well understood. So in a healthy immune system, autoantibodies are produced frequently. So we all know that everybody has multiple different cancer cells in the body on any given day, and that's just part of normal mechanism. But we have counter-regulatory mechanisms in place to kind of nip that in the bud. So and to bring the body back into balance. So the immune system and autoimmunity is exactly the same. We have autoantibodies that are produced all the time, but in a healthy immune system, that production is immediately nipped in the bud. So immature B cells have to pass a special test before they're released into the bloodstream from the bone marrow. And if they don't pass that test because they're predisposed to being autoreactive, then they shouldn't be released. So the thymus cells can also weed out autoreactive T cells before they're released into circulation. And so both of those cells, the B cells and the T cells, if they're not working appropriately, should be killed by the immune system before they are released into the systemic circulation. And if they are released into the blood or into the lymph, then the T regulatory cells should come in and weed that out. So that's how healthy immunity works. But of course, in autoimmune disease, the mechanism isn't quite that black and white anymore. So autoimmune disease is all about tolerance, immune tolerance is a general term that basically describes a state in which the immune system is not reacting. So your immune system has quite a few jobs that it does, but when it comes to identifying that there's a problem that requires response, first of all, the immune system is saying, is this self or is it stranger? And once it's identified, okay, this is self, that should have then an anergic response to it, which means no response. Your tolerance is the response when it's self. If it's identified as being stranger, the immune system then has to say, yes, but is that a non-threatening, friendly stranger, or is that a dangerous stranger? Because if it's a non-threatening, friendly stranger, we're not going to be responding to that either. So again, the reaction is actually tolerance. And then if it's a dangerous stranger, of course, then we need to have a reaction. So tolerance, though, is not a passive state. It's actually an active, purposeful function of the immune system. So it's kind of defined as suppression of immune response. But there are lots of different signals, lots of communications, lots of different mechanisms in place that actually create the messages of tolerance. So it's not just no reaction, it's specific reactions of peace rather than specific reactions of war, which is what we see in immune response. So central tolerance basically revolves around the thymus gland, and if you have even a single mechanism that goes awry there, then we can actually end up with that kind of warrior response instead of the tolerance response. Peripheral tolerance, of course, happens once those T cells have been released from the thymus gland into the systemic circulation, and once the B cells have been released from the bone marrow and into the systemic circulation. So again, that tolerance revolves around suppression of auto responses and suppression, like appropriate switching off of immune responses at the end of inflammation. And then oral tolerance happens, of course, in the mouth and gastroenteric tract. So oral tolerance, we kind of think about it as GALT, but actually it does start in that oral cavity. So we've got that nasal associated lymphoid tissue up in the sinuses that is perfectly capable of launching a total immune response. You can stimulate celiac disease from the nasal associated lymphoid tissue without swallowing any gluten, for example. So oral tolerance starts in that in the sort of respiratory mucosal surfaces of the mouth and the sinuses, and then goes all the way through to the gut. And oral tolerance starts to be established at birth or after birth. And because the mucosal surfaces are the largest interface between the environment and the systemic circulation, oral tolerance is critical to immune tolerance. And oral tolerance is often broken in autoimmune disease, which we see characterized by inflammatory reactions to foods and inflammatory reactions to microbes on the gut wall. both of which we're supposed to be tolerating. The other thing, of course, is that when you have broken tolerance in one area, that often leads directly to broken tolerance in other areas. So you can break oral tolerance by having broken systemic chemical tolerance, for example. It might not be that oral tolerance is where it starts, but because you have a problem with chemicals systemically and you've broken tolerance via a different mechanism, that you now have broken oral tolerance, and that will lead you to food reactions, even if that wasn't the initiating trigger. So understanding where the problems with tolerance are and how to support tolerance and how to repair tolerance once it's been lost, of course, is a really primary part of working with someone with autoimmune disease, teaching that immune system to switch off the messages of war and to start to bring back messages of peace and tolerance. Is appropriate not just for our political climate, but also for our internal environment. So it is generally understood that to develop an autoimmune disease in the first place, you need to have 3 variables in place. So number 1 is genetic predisposition. Number 2 is broken immune regulation characterized by barrier permeability of some kind. So we generally talk about gut permeability, but you can have leaky gums, you can have leaky lungs, you can have leaky skin, you can have leaky blood-brain barrier, and any one of those is capable of being the broken barrier. Although we primarily do focus quite a lot, for obvious reasons, on that gut interface. And so once you've got a genetic predisposition and you've got disturbed immune function because of interrupted barrier function, and you also have an environmental trigger, then we have this perfect storm that leads us down the pathway of autoimmune disease. And so all of those things need to be considered when you are working with someone with autoimmunity. So I'm going to start with talking a little bit about genetics. And so the importance of understanding genes in autoimmunity was emphasized because they noticed that the risk of autoimmunity is dramatically increased in twins and siblings and first-degree family members of affected individuals. But genetics and environment, even when you have a very strong, let's call it a twin genetic susceptibility, environment still plays a really big role. So most of the research into the specific genes involved in autoimmunity focuses on this HLA typing. And HLA typing, so human leukocyte antigen, is categorized into multiple different classes. So we have, and I've actually forgotten them off the top of my head, but it's like HLA, C, D, and E, and then you've also got C, D, E, no, A, B, and C, and then D, and E, I think it is. And so A, B, and C are associated more with no, let me reverse that around. So in the beginning, it was kind of thought that the HLA-D variants were more associated with autoimmune disease. And so a lot of the research was focused there. And as more research has been done and we've looked at things a little bit closer now, we're starting to see some of those earlier categories of the HLA typing, so the Bs and the Cs, also associated with autoimmunity. And the reason that I think it's important to understand that is because the HLA, when we're talking about HLA, what we're actually talking about is a region of the gene that codes for antigen presentation. And antigen presentation is the part of your immune response that is going to determine how you respond to your environmental trigger. So when you have a gene that predisposes you for autoimmunity, you don't have a gene for autoimmune disease. What you actually have is a gene that makes you more responsive, that makes your immune system more responsive and more inflammatory in the presence of an environmental trigger. And so then we start to see, okay, the HLA regions that are associated with specific autoimmune diseases actually make more sense if we understand that the HLA-Ds are associated with a specific form of antigen presentation that is more to do with extracellular issues, and the HLA-Bs, for example, are more associated with antigen presentation cells that respond to viruses. So now we start to see how bacteria and viruses and various different environmental stimuli are more likely to contribute to this autoimmune disease or that autoimmune disease, because it's not the gene for autoimmune disease, it's the gene that tells you how you're going to respond to a virus. That predisposes you to having autoimmunity when the other variables are also in place. So I don't know that I've explained that clearly, but hopefully that makes sense to you. So it's actually a lot more complicated than just, do you have the gene? Because of course, for example, in celiac disease, 35% of the population are HLA-DQ2 or DQ8 positive, but only 1%-ish of the population have actual celiac disease. So there always needs to be that extra layer of a variable in the specific person's case, and that might be stress, and it might be alcohol, or it might be you know, there's always got to be something else that predisposes that person to developing, that actually, not predisposes is the wrong word, they have the predisposition that guarantees the outcome. It's not just as simple as, do you have the gene? So if you're not doing comprehensive genetic screening in your clinical practice, and that's a joke because I know some of us do work with genomics, and I do as well, but I promise you that none of them are comprehensive to the point that it really helps us to understand what's going on, because science isn't, we don't have that access yet. One of the most simple ways, of course, of understanding genetic predisposition is to look at the family. So the highest risk for first-degree relatives for developing Crohn's disease is actually up to about 20%. So that's a 1 in 5 risk. And we absolutely see autoimmune diseases clustering in families. So I know that all of us really are asking about family. So we're asking about mum and dad, we're asking about siblings, we're asking about grandparents, but we need to be asking questions around aunties and uncles, like what's going on with the parents, siblings as well, and asking specific questions around things like psoriasis and type 1 diabetes, and things that aren't necessarily going to be obviously popping up on the intake forms because that patient maybe hasn't thought about it. But it is such a, when we're thinking about prevention, and especially in children, or does this person have an autoimmune disease? Do I need to be thinking about that because they're not diagnosed yet, but they are symptomatic of immune dysregulation, and there's obviously something going on here? Family history is the first place to look, and we often see 2 or 3 or even more different kinds of autoimmune disease that come up in the same family. So it's not that common to see everybody has celiac disease or everybody has Hashimoto's, but what we do see is Uncle John has rheumatoid arthritis, and Grandma had Hashimoto's, and somebody else has psoriasis, and now this person has celiac disease. So it's always the first place to start, especially when we're thinking about prevention. And it is, the other thing, of course, is that it's not just as simple as the straight genes. Now, we also understand more about genetic SNPs, and we also understand more about epigenetics, like what genes have been switched on and what genes have been switched off. So I'm also now looking, when I'm talking about family history, I'm talking a lot about stress and trauma and famine and war, and I'm asking things about, you know, did your grandparents you know, were they in an environment where there was war or deprivation or major stress of any kind? Has your family undergone any kind of trauma back through a couple of generations? Because those things change the way our genes behave. They change the way our nervous systems respond, and stress is such a big part of developing autoimmunity. And what happened in that grandmother and what happened in the mother has a big impact on what happened in the person who's sitting in your clinic on that particular day. We also know that SNPs are very, very involved. And again, it's becomes very complicated, but you're looking for things that are going to change the way the immune system responds. And all of those have a big impact on that. So understanding epigenetics around stress helps you to understand how this person's immune system responds, and especially how it responds to infectious agents. SNPs also help us to understand if there is a predisposition towards inflammation down a particular pathway, which again, even if that gene is not directly involved in autoimmune disease in the conventional sense of thinking, it still helps you to understand why someone's immune system is hyperreactive. So, okay, so that's family history. But of course, genes load the gun, but the environment pulls the trigger. So at the end of the day, genes make up about 20% and the environment makes up the rest. So we're really going to be talking a little bit more about environmental triggers. So mucosal immunity is really important to understand when you're talking about any kind of immune system issue. So the gut sees more information, the gut sees more action, the immune system in the gut sees more action in a single day than the systemic immune system sees in a body's entire life. And a very large amount of the active immune system in a body in the day is actually found in the small intestine. So your mucosal surface in the gut is the major interface between the environment and the body, and essentially acts as an environmental translator. So it's one of the first places that the immune system starts to get messages that end in inflammation or that end in tolerance. So anything that you can do to support digestive health and gut health is going to be of paramount importance in somebody that has irregular, disrupted inflammatory immune function or end-stage autoimmune disease. Oh, there we go. I've already said that bit. So yeah, so because of food and because of the sheer number of bacteria and microbes that come in to the gut, just the food and our intestinal microbiota is more work in a single day than the internal immune system should be seeing in your entire life. So gut bacteria is incredibly important to immune system messaging and immune system tolerance. And what we see in people with autoimmune disease is that their microbial ecology is different than people who have a healthy immune system and a healthy gut. Now, they haven't quite managed to narrow down the specifics. And I think that, of course, that tends to be the direction that medical research takes. They want to know exactly which bacteria are going to cause autoimmune disease. But we know that the body doesn't really work that way, that each microbiome is like a fingerprint. And the reality is that gut bacteria, we tend to separate that into and we have in the past really thought about the microbes in our body as being either good or bad, but there are many, many different shades of grey because it's all about context in the body. And a bacteria is not no, there are many things that determine whether or not a bacteria or a virus that's found in the body is good, bad, or benign, not just what that bacteria is. So, for example, we now know, having looked a little bit more closely at SIBO, that a beneficial bacteria that's supposed to be in the colon becomes a very bad bacteria when it's found in the small intestine. So the bacteria didn't change. We used to think about that as a good bacteria, but because it's in the wrong location, it's now causing significant immune system dysregulation and inflammation and symptoms in the person. So the type of bacteria is important, where it's found is important, the other microbes that are in the area with that bacteria, so the population surrounding that bacteria will determine whether or not it's good or bad. The number that it's found in will also determine if it's good or bad. So you can have a really severe overgrowth of a good bacteria, and because that is indicative of a very imbalanced microbial ecosystem, that's an unhealthy gut, even if the bacteria itself is quote unquote good. So just identifying that there's a bacterial problem or that there is a bad bacteria present doesn't tell us whether or not there's a problem or whether or not that gut is healthy. We have to actually zoom out a bit and look at the entire ecosystem. We need to look at all of the digestive markers and understand how the food is going to be interacting with that gut bacteria. Because if you've got appropriately broken down and partially digested food that's interacting with an appropriate microbe in the appropriate part of the intestine, then that is much more likely to set you up for healthy immune responses. But if you've got inappropriately digested amounts of food, like if that person hasn't chewed their food properly and it's still got way more carbohydrate in it because it hasn't been broken down by the salivary amylase, and that reaches a microbe in the small intestine that loves to ferment carbohydrate, then you're essentially setting that gut up for inappropriate function and to be slightly pro-inflammatory. So understanding how the digestive system impacts the microbial ecology and the food interacts with the bacteria in the gut helps us to understand whether or not that gut is healthy, yes or no. So digestive function is really important, not just looking at the microbes, and that's all the way from signaling from the brain, because we all know that digestion is a top to bottom process. So it starts in the brain, then it comes to the nose and the mouth, then we swallow, then it comes to the stomach, then in the duodenum we have pancreas and bile and enzymes from that brush border, etc., all the way down. So if you're trying to address a microbial issue in the bowel or a microbial issue in the small intestine, and you haven't actually worked on what's going on with the digestive system further upstream, it's going to be very difficult to restore healthy function to the small intestine if you haven't looked at what's going on in the stomach and the mouth. So zeroing out and looking at the big picture, the overall microbial ecology, the health and the pH of the guts, and what's going on with digestion all play a really big role in restoring the healthy gut bacterial ecology. Which again then sets us up for tolerance, which is the point of all of that, is that the gut wall is such a big site for tolerance, and if that's broken, it's such an important part of us resolving it. So then barrier permeability, of course, plays a very, very big role in tolerance and intolerance. So, of course, what we're looking at here is the gut wall, and I don't really think I necessarily need to be talking to all of you about what is leaky gut. I feel like you all know what leaky gut is and why it's a problem. So my point even in bringing up this slide, of course, is that I want you to be thinking about barrier permeability outside of just leaky guts. So we actually need to be thinking about barrier permeability, not just leaky gut. And it's why when I talk about, so I think in my intro, I probably did have, I probably need to update that, because I think I do talk about why leaky gut is involved. But actually, I want you to be talking about or thinking about barrier permeability, not just leaky gut, because more and more what I'm seeing in my clinic is problems in other areas as well. The genitourinary tract, the lungs, the sinuses, the skin, the gums, and the blood-brain barrier. And the mechanism is the same in each of those areas, you know, to the point where we're talking about zonulin and occludins and claudins, you know, literally the structure of the barrier in the gum is exactly the same as the structure of the barrier in the gut, which is the same as the structure of the blood-brain barrier. So we're talking about when you're increasing zonulin in one area, it's increasing zonulin systemically. And when zonulin is increased, then those occludins and claudin proteins that hold those tight junctions closed relax and the tight junctions open. And that's not just happening in the gut. If it's happening in the gut, it's also happening in the blood-brain barrier. It's also happening on the gums, we assume, because the mechanism is exactly the same in multiple different locations. So I also we're talking, of course, about gut bacteria, but we need to be thinking about dysbiosis and symbiosis in the entire body. You know, Alex Vasquez talks about, I can never remember the phrase that he uses though, he talks about multifocal polydysbiosis, which means having dysbiosis in lots of different areas all at the same time. And we essentially, if we're only focusing on the bowel and the gut and the dysbiosis in that area, and we're not also working in the same time on what's going on in the mouth and what's going on the skin and what's going on in the other areas, and we're only working on restoring gut health, of course that's a big part of it, but it might be that we need to be working on multiple different areas at the same time, because when you have dysfunction in one area, it affects all of the other areas as well. So you'll move forwards faster if you're thinking about all of the locations that somebody has dysbiosis and not just working on the gut. So barrier permeability, very, very important, because again, it sets you up for inappropriate immune system messages inside the body, and directly triggers inflammatory messages and inflammatory cascades that you know, that affect the joints, that affect the tissues, that affect basically any inflammation anywhere in the body. I suppose the last point, which I feel like I'm assuming that you all know, and so I wasn't going to say it, but in the end, because this is a student webinar, maybe I actually really do need to say it, of course, is that barrier permeability and having bacteria that cross into the systemic circulation and creating this endotoxemia, or having food that crosses you know, the barrier and into the systemic circulation, that mechanism can directly lead to autoantibodies. So there is probably a 5 or 6 step pathway that ends in autoantibodies. So it's not just that you are, it's not just that you are creating a pro-inflammatory dysfunctioning immune system. It's that can exacerbate existing inflammatory issues in autoimmune disease, but that can be the direct mechanism by which autoimmune disease is triggered in the first place. So you need to be considering both of those things. Is it the primary trigger, or is it something that's perpetuating an existing problem? Either way, you need to be identifying it and working to repair that tissue. Okay, so environmental triggers are essentially divided into 3 general categories. So we've got environmental toxins, we've got infectious agents, which is bacteria and viruses, and we also have food. And I have recently added a 4th one to that, which is stress and trauma. But in a general sense, the established understanding is that it's these 3, and so that's predominantly what I'm going to be talking about today. So firstly, chemicals. Now, chemicals are very, very small. They don't actually trigger an antibody response by themselves. So what happens is that when you have toxic exposure, this breaks down physical barriers. So chemical exposure helps to create barrier permeability, and that can be any of the barriers themselves: guts, skin, lungs, etc. So the chemical, so firstly there's that. That's a very direct way of how chemicals contribute to autoimmune disease. Then chemicals themselves are very inflammatory, and they change the way the body works. So that might be that they're creating a lot of inflammation or a lot of oxidative stress, and that in and of itself can be enough to trigger or to create immune dysfunction that is part of the antecedent of why somebody develops autoimmunity, because they're inflamed because of their chemical exposure. Or chemicals can be a direct trigger. So chemicals themselves can actually bind, in fact they do bind to human tissue, and when a chemical has bound to human tissue, that human tissue no longer looks like human tissue to the immune system. So that protein, that tissue is changed. It no longer looks like self anymore. So the immune system no longer recognizes that tissue as self, and that's a problem, because of course it's not self anymore, so it's eliciting an immune response, and it's certainly not identifiable as a friendly stranger. So chemicals bound to tissue can create a direct immune response that initiates T cells and B cells antibody production to the specific tissue that the chemical is bound to, and that leads to inflammation and autoimmune reaction. But it's not possible to live a toxin-free life. And so many of the toxins, I mean, we're just living in a completely toxic soup at the moment. It's very stressful when I think about it, which I do because I teach about detoxification. You know, essentially everything in our home, in our clothing, in the air that we breathe contains some kind of contamination. And so the toxins that I'm looking for when I'm working up a case of autoimmunity, I am of course thinking about big toxic exposures. I am thinking about, did you live on a farm? You know, I've got multiple people in my clinical practice who have done things like sheep dipping and had really big toxic exposures. But actually, so many of the toxins that are contributing directly to autoimmune disease are found in a small level on a daily basis. So there are things, when we see that the toxins that you see here, they are things that are found in the cosmetics that we're using, in in the dental work that we had done when we were a teenager. They're found in the IKEA bookcase that we have in our home. They're found in the peanut butter or the nut butter that we're using. You know, they're found in small levels on a daily basis in our home, and we are all being exposed to them. And part of the issue, of course, is that we have a tendency not to notice things that are happening on a small scale. And a lot of these foods are found, a lot of these toxins are found in a minute quantity. But the body is designed to respond to things that are microscopic. You know, a virus is miniature, it's so small, and even me just saying so small doesn't really demonstrate to you how minuscule a virus actually is, and yet it's capable of eliciting a massive inflammatory response. You know, BPA is found in parts per billion, you know, 0.5 parts per billion, which is 1 grain of sand in a sandbox. It is, you know, 1 drop of water in a bathtub. It is a minuscule amount. But hormones are also found in that kind of tiny quantity in the body. You know, hormones are also measured in parts per billion. And picograms, actually, sorry, hormones are measured in picograms, which is, you know, minuscule quantities. So these things add up. You know, they are capable of eliciting a very large inflammatory response in the body. And with toxins especially, 1 + 1 does not equal 2. 1 + 1 can equal 50, and 1 + 1 can equal 100. And what I mean by that is, if you have a few of them, so if you have a little tiny bit of mercury and a little tiny bit of BPA, and you also wear nail polish or get your nails done, then all of those things combined together in the body equal much more than the sum of the individual parts. So toxins are something that, even if somebody doesn't have a big, obvious environmental exposure, you very much need to be considering as part of working with someone that's got inflammatory or autoimmune issues, because small amounts have such a big impact on the way the immune system works. So then infectious agents. So infectious agents are possibly one of the best studied triggers of autoimmune disease, because it's pretty well understood. Again, with infectious agents, we tend to think about things in 2 main categories. So we have acute infection and we also have chronic infection, and both or either of those can be involved in autoimmunity. So chronic exposure to a pathogen tends to set us up for disturbed immune function. So pathogens tend to change the communication within the immune system. They can inhabit B cells, they can inhabit specific tissues in the body. And once on board, they can actually change the communication between T cells and B cells. They can collapse part of our T cell response, and they can make other parts of T. So, for example, they can shut down Th1, but they can upregulate Th17. They can shut down T regulatory cells to a certain extent because of inducing NF-kappa B, or they can inhabit B cells and change the way that B cells and T cells communicate in the case of Epstein-Barr virus. Another issue around pathogens is that pathogens actually excrete biotoxins, and biotoxins can accumulate in tissue. So it's not necessarily the bug itself, it's actually the metabolites that the bug creates. And those biotoxins can be very inflammatory, very toxic to the system, and very difficult for humans to actually excrete and get rid of properly. So we tend to see that in things like Lyme and mold, and sometimes in yeasts as well. So undetected, I mean, we are a human microbe kibbutz. We are supposed to have a lot of bacteria, yeasts, and viruses on board. So we have a lot of mechanisms for living in harmony with bacteria. And so we can live with an undetected pathogen on board, or you know, with a potentially bad guy on board without it actually causing problems for a really long time, or because there's been a minor disturbance in immune balance with that pathogen creating problems on a low level for a very long time below the surface. And so what I often see is that there's been a chronic infection operating at a low level that wouldn't have caused a problem, except that there has been a third variable. And that third variable is often stress or trauma of some kind. So it might be a divorce or a bereavement, or it might be a very stressful job or something along those lines. It might be a sick child. Or it can be a toxic exposure because that person has very poor detoxification genetics, and so they're really susceptible to inflammation from toxins, and they're doing a job such as they're a hairdresser that puts them in contact with an elevated amount of toxic chemicals on a daily basis. Excuse me. But so pathogens are always on my mind when I'm thinking about autoimmune disease, because of course we have so many pathogens on board. And because we are, you know, the genetics involved in autoimmune disease do tend to be associated with response to pathogens. So I am always thinking about how a pathogen's involved from an immune system perspective, and from a trigger perspective, and from a perpetuation perspective to an inflammatory issue. So in the next diagram, we actually see dysregulation of immune system balance, which is triggered here by infectious agents. So you've got your antigen presentation cell, and you have this is a virus. So that virus is being presented to the antigen presentation cell appropriately. The APC is responding, and that's triggering a bunch of pro-inflammatory cytokines. And the pro-inflammatory cytokines inhibit T regulatory cells, and they upregulate basically inflammation and antibody production. So that is one of the pathways through which autoimmunity is triggered by a pathogen. And in an acute infection, at a certain point, the immune system wins, and that whole process is shut down. And when you stop making TNF alpha and interleukin 6, T regulatory cells are switched back on again, and so your immune system comes back into balance. But when that infection is chronic, and or combined with something like vitamin D deficiency, which is very important for T regulatory cell function and FOXP3 activation, then you have this low-level suppression of T regulatory cell function and this low-level upregulation of inflammation that happens. And over time, that cascade leads to increasingly larger amounts of inflammation and damage to tissue in the body. And this is the cycle that we see set up in autoimmunity. And of course, that's perpetuated by inflammatory diet, that's perpetuated by stress, that's perpetuated by lack of sleep. Like, it's not just the single mechanism that's involved, it's when this mechanism is activated alongside the other variables in that person's life. that allow it to become problematic over time. So there are multiple different ways that infectious agents can contribute to autoimmune disease. So we have this direct disturbance of immune homeostasis. We also have molecular mimicry. So, and again, this is really well studied, where the immune system is designed to respond. So remember this from digestion. Your immune system doesn't respond to individual amino acids or to dipeptides, which is how our food is supposed to be broken down into by appropriate digestion. But once you have that third amino acids in a peptide or larger, the immune system can identify that and respond to it. So whenever you have a 3 amino acid sequence or larger that is flagged up by the immune system as being a problem, that amino acid sequence is capable of triggering an immune response in an immune system that has been primed to respond to that pathogen. So here we have cytomegalovirus. And GAD65 is an enzyme that is, it's actually, so antibodies to glutamic acid decarboxylase are one of the identifying antibodies of type 1 diabetes, but glutamic acid decarboxylase antibodies are also found in the brain, and so antibodies to this specific part of the tissue or this enzyme are found in things like gluten ataxia and stiff person syndrome and neurological autoimmunity in general. And very responsive, by the way, to so this molecular mimicry that I'm about to explain also is relevant to gluten and GAD65. So it's not just to infectious agents. But so basically, once somebody has had a cytomegalovirus infection and the immune system has been taught to respond to this particular amino acid sequence, what we now see is actually there is this protein and this protein look very similar to the immune system because they share this direct amino acid sequence and then some extra sort of amino acid pattern. So once the immune system has established that it needs to be responding to cytomegalovirus, its memory cells are roaming around the body forevermore looking for this amino acid sequence. And what we see then is that the chance of it being able to respond to GAD65 are massively increased. Now, in a healthy body and in a healthy immune system, that might happen and then be shut down by our counter-regulatory mechanisms. But in an immune system that's stressed out, hyperreactive and inflammatory, the chance of it actually starting to respond to this amino acid sequence in self-tissue are heightened, they're elevated. So molecular mimicry is one of the ways that bacteria and viruses can directly trigger responses to tissue because the tissue looks like the infectious agent that the immune system has been taught to respond to. So some other common mechanisms for infections and autoimmune disease includes bystander activation, which is essentially collateral damage from the inflammation. So once an infection has set up inflammation in an area, the actual act of the immune system responding to that infection and to repairing the inflammation can create more inflammation. And we see that, for example, with neutrophils. So when a neutrophil is responding to damage caused by an infection, even at a low level, that neutrophil itself can actually start to damage the tissue in the surrounding area. That damaged tissue then causes more neutrophils to come in, and more neutrophils then start to respond. And when that mechanism is not appropriately shut down, the tissue damage caused by the neutrophils, which were responding to the infection, actually start to trigger their own immune response, which creates antibodies because you're repairing tissue. and that then becomes autoimmune, and that's bystander activation, where it's basically just collateral damage. And then very similar is epitope spreading. So the immune system is responding to a tissue that includes a protein, and then as part of that immune response, and we see this with T cells more so than neutrophils. So the mechanism is very similar, but it is a different part of the immune system that causes it. So essentially, if you have a molecular mimicry response to a particular tissue triggered by a microbe, and the inflammatory response and autoimmune reactions aren't stopped appropriately, then over time you can start reacting to other proteins as well as that original one. So the original damage was from the microbe, and the original mechanism was molecular mimicry, but that infection has gone on to create this epitope spreading. And so that is another mechanism by which autoimmune disease is triggered by infection, a little bit more indirectly. So here are just a few of the pathogens that are associated with autoimmune disease, but essentially it can be any. So these are these are some of the common ones, but again, you can be having autoimmune responses to your own microbiome. So it's not so much just around the specific infection, although I do want you to be thinking in that way. It's also about how is the immune system responding and what's going on with the total microbial load in the body. So then, of course, diet. So there are lots of different ways that diet contributes to autoimmune disease, and it won't come as a surprise to you that the Western diet has been directly implicated in autoimmune disease. So any diet that is pro-inflammatory in nature because it has damaged fats, high processed carbs, high sugar, low fiber, etc., creates a baseline of inflammation in the body. And when you combine that with genetic predispositions, stress, infection, chemicals, then that can lead to autoimmune disease over time. So diet can be an antecedent to developing autoimmune disease. It can also, of course, be a direct trigger, and it can be a perpetuator as well. So so the pro-inflammatory diet can be an antecedent, and it can be a perpetuator, and then specific component parts of the diet can be a direct trigger for autoimmune disease. So gluten is possibly the most talked about food protein in conjunction with autoimmune disease, but I hope that all of you, if you're new to this because you're a student or you've been practicing for a little while, I sincerely hope that all of you are going to start thinking a little bit more broadly than just gluten, because the reality is that any food can be an autoimmune trigger, and because of that molecular mimicry mechanism that I've described relative to bacteria and viruses, molecular mimicry can occur between any food and any tissue in the body. And so, for example, a study that was published, I want to say last year, showed that there are, but I've forgotten the number now, a very large number of foods that cross-react with thyroid tissues. And some of those foods include food that we would recommend for somebody that has thyroid illness, such as seaweed and Brazil nuts, because they contain iodine and selenium, which are good for thyroid health. And also, you can be having direct autoimmune reactions to foods that are included on a autoimmune paleo diet, for example, such as salmon or spinach. You know, the mechanism is, does it have an amino acid sequence that the immune system is capable of responding to? And if the answer is yes, and that amino acid sequence corresponds to a specific tissue in the body, then it doesn't matter what the food is. It doesn't have to be a quote unquote bad food. But again, this is where digestion becomes really, really important, because your immune system will not respond to an individual amino acid or a dipeptide. It only responds to foods that are partially digested and crossing, that are partially digested or undigested, and the immune system response is set up when you've got broken broken oral tolerance. So digestion becomes incredibly important, because if you're appropriately digesting your food, it should be being broken down into individual amino acids and dipeptides, and they should not elicit an immune response. That's not possible in some cases. The human immune system doesn't break down gluten and casein properly, for example. And I'm certainly not suggesting that if you take the right kind of digestive enzymes that somebody with autoimmune disease can eat gluten or dairy, but I am saying that digestion becomes incredibly important for restoring oral tolerance when somebody is reacting now to everything that they're eating. So gluten specifically has been linked to several autoimmune diseases. So celiac, of course, dermatitis herpetiformis, type 1 diabetes, Hashimoto's, but we also see that people that have got celiac disease have a very strong, in fact, people that have, anybody that has one autoimmune disease has a very strong chance of going on to developing a secondary or a tertiary autoimmune disease. I think it's something like a 25% of people that have one autoimmune disease go on to develop a second or a third or even more. You know, I have people in my practice that have 4 or 5 diagnosed illnesses. And so here is a list of autoimmune diseases that have been specifically implicated in specifically associated with celiac disease. And so then that does bring with it the question, why these ones specifically? Is there also a reaction to gluten that's going on there? Or is it just that once that mechanism has been initiated, that these are these are just some of the more common autoimmunity? It's not very well known yet. So beyond being a direct trigger and or setting you up for inflammation, when you're using diet as a tool, you need to be thinking beyond. So you need to be thinking, what are the direct triggers? And you need to be doing some testing around what are the direct triggers, and not just putting people on an autoimmune diet, but understanding what are their individual triggers. But you need to be using diet as your tool, of course, for doing all of these things, not just eliminating. So no diet should be defined by what's missing. We always need to be defining a diet by what's actually present. So it's totally possible to have a diet that doesn't help to support the immune system, even if you've taken out every aspect of that diet that is essentially pro-inflammatory. We want to be using food to alleviate oxidative stress, which is extremely high in people with autoimmune disease and can actually be part of the mechanism by which autoimmune disease develops. So we want to be thinking high antioxidant levels and phytonutrients. We want to be using diet to alleviate dysbiosis. Of course, we want to be reducing reactivity to dietary antigens, so gluten-free, dairy-free, identifying what the triggers are. We want to be using food to help to normalize intestinal permeability and restore barrier function. So that's things like using apples and bone broth, and using foods in a therapeutic way, using teas to help to restore physical function. And we also want to be using food to help to support mitochondrial dysfunction, which is often disordered in autoimmune disease. Remember, fatigue is the number one trigger. It's the number one symptom that's most reported in autoimmune disease and is common to every autoimmune disease. So supporting mitochondria helps people to feel better and helps their immune system to work better. So some of the dietary considerations that you may be thinking about are improving the dietary quality. So traditional foods, how are they being prepared, high nutrient density, how are they eating, etc., etc. Supporting the gut microbiome with probiotic and prebiotic rich foods. So prebiotic fibers, fermented foods, and things like that. There is a very good paper called Feed Your T-Regs More Fiber, which basically says that the more prebiotic fiber and the more variety of fiber that your person is eating, the more butyrate they're making, hopefully, and butyrate directly contributes to tolerance. So in order to restore immune tolerance in somebody, you need to be supporting T regulatory cells, and to do that, they need to be eating enough fiber. You're going to be looking at reducing dietary antigen exposure, of course, and there's lots of different ways that you can do that: elimination, reintroduction, IgG and IgA based elimination. There's lots of different methods for identifying when food is a problem, but I do think that testing is necessary in autoimmune disease. I don't think that you can guess. And then you may be looking at very specific regimes, and I hope that you wouldn't stick to just a single one of those all the way through. You basically need to be changing the diet that your person is following, and first of all, personalizing it for them and changing it as their needs change. Because a low FODMAP, low specific carbohydrate SIBO diet, etc., can be very necessary for getting a disordered gut under control, but long term is really problematic because, of course, it's low fiber and not very good for immune tolerance. So here are some of the specific foods that you may feed your Tregs with. And here are some of the other interventions that you might be considering to support your T regulatory cells. I'm not going to read all of these out because I'm pushed for time a little bit right now, but you can all download the handout from BANT that has them on there. There's some references for T regulatory cells, and I've included basically 2 strategy checklists for you. So when you're restoring oral tolerance, these are all of the things that you need to consider because they help you to reduce the antigenic load, to restore and rebalance disordered immune mechanisms in the gut. So, for example, stimulating endorphins helps to calm down, what are those things called? Dendritic cells in the gut, which are very important for establishing tolerance. And we see broken tolerance when people have overreactive pro-inflammatory dendritic cells. So endorphins are very good for that. And you may need to consider and work your way through all of the variables listed here. So you need to be thinking way outside of just, have I given them secretory IgA support via Saccharomyces boulardii and glutamine? There's lots of things to consider. And then in the overall, you need to be considering the whole person and using your functional medicine matrix. So don't just be thinking in terms of, does this person have multiple sclerosis? What's the protocol for that? You need to think about the history. You need to think about them, and you probably need to be optimizing all of the variables in their specific case. So you need to be identifying triggers and mediators of inflammation, and that's foods, environmental toxins, stress and trauma from their childhood, from their mother. You need to be looking at their hormones. If you're not working with hormones, it's very difficult, and at least considering hormones as part of the whole clinical picture, it can be very difficult to get the immune system under control. Identifying and supporting nutrient insufficiencies, and considering, of course, bacteria and viruses. And there's lots of different things outside of food that you need to consider as well, such as sleep and social support. And do they need to divorce their husband? Frankly, there's lots of different ways that you can support immunity in an individual, and they all need to be assessed and addressed individually. So I've got like 2 minutes for questions. Alma, if there's any. Otherwise,
Robyn,
you can send me an email, and I will. I'll answer email. I'll answer questions by email.
I just want to say thank you very much for that. It was really very comprehensive, and if that is just an introduction, then we can only imagine how complex this whole topic is. But so it was really.
I'm putting together a 3-day course on autoimmune disease, so 1 hour is a toe in the bathwater.
Anyway, I find it really interesting. I'm sure everybody else is. Just a very quick question. So do you have to have genes to have specific genes for autoimmune disease? For example, do you have to have DQ2 innate for celiac, or are there some people who don't have these genes but they develop celiac?
So the answer to that is yes, because it's not really that well known. But with celiac disease specifically, it's estimated that about 2% of people with diagnosed celiac disease do not have DQ2 and DQ8. But in clinical practice, the doctors seem to dismiss that 2%. So I mostly find that my patients are told if they don't have DQ2 or DQ8, then they don't have celiac disease. But I think while 2% is still 2 people out of 100 people with celiac disease, that's not none, you know.
So it's still possible. And just last question is, we know that gluten is a trigger for celiac, but for all the other autoimmune diseases, do we know of a specific trigger, or is it just a mixture of things and it's still not identified?
It's a mixture of things. Everybody's autoimmune disease is really unique to them. And even in the case of celiac disease, I am finding that people tolerate gluten. It's like, what is making them lose tolerance to gluten? There's another third-party variable there, and it might be stress, it might be another infection, it might be a chemical exposure. Like, we know that gluten triggers celiac disease, but people develop celiac disease age 65, having tolerated gluten their entire life. So it's not necessarily as cut and dry, and they're still researching it. It's, you know, so we don't know most of the time, but there are, like, gluten is very common, dairy is very common, some infections are very, very common. You know, Epstein-Barr virus, for example, is very common as a trigger for things like Sjogren's and scleroderma and you know, autoimmune liver diseases, but it doesn't mean 100% of the time. Yeah.
Thank you. Thanks for everything. These are all the questions that we have. I'm sure if anybody else has any more questions, then you can email student webinars, and I'm sure that Robyn will be very happy to answer these questions. Also, as Robyn already mentioned, the presentation and the recorded webinar will be on the BANT website within a week, so you can go and check it out and you can download it if you wish to. So I just wanted to thank Robyn once again for taking the time out of your busy practice to speak to us. And I also wanted to thank all the students for attending the webinar. So Robyn, is there anything else you'd like to add?
That's all. I hope you all enjoyed that. And you can find me on Instagram if anybody wants to say hi as well. I really like interacting with people there.
Brilliant. Well, thank you once again, and I hope everybody has a lovely day.
Have a great day, everybody. Okay, bye-bye.
Bye.